Welcome to VerifiedRx, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
Widespread vaccination efforts declared measles eliminated in the United States in 2000. However, recent outbreaks have reignited public health concerns. The country is experiencing a growing number of measles cases, with clusters reported in several states. A highly contagious virus, measles, poses serious risks, especially to unvaccinated individuals and vulnerable patient populations. Dr. John Schoen, Senior Clinical Manager of Drug Information at the Vizient Center for Pharmacy Practice Excellence, and my Vizient colleague, joins me to discuss the current outbreak, measles vaccine strategies, and to answer questions about prevention and public health impact. I'm Stacy Lauderdale, Associate Vice President at the Vizient Center for Pharmacy Practice Excellence and your VerifiedRx program host. There's a media spotlight on measles right now. So I thought it'd be a great opportunity to have John back on the podcast to discuss measles. Welcome back to the podcast, John.
Thanks, Stacy. Glad to be back.
Well, John, I will tell you that I have scoured social media to figure out what are the public's questions on measles. And today on the podcast, I'm really going to try to hit some of those questions so that we can answer those questions for our listeners. Last week, I read that Quinnipiac conducted a survey, and that survey found that almost 70% of the respondents were very concerned or concerned about the measles outbreak in Texas and New Mexico. And I know that outbreak has now extended to other states since that survey was conducted. What is the current situation right now with the measles outbreak? And are we in an unprecedented situation that we've never been in the United States?
As of March 20th, there have been 378 documented cases of measles in the U.S., and infection has predominantly occurred in unvaccinated individuals. So approximately 95% of the infections that we've seen have been in unvaccinated persons, the majority of whom are children and adolescents. There's outbreaks in 4 states. Outbreaks are defined as 3 or more cases. So currently Texas, New Mexico, Oklahoma, and Kansas fall into that category, with the majority of all of the cases occurring in Texas. Over 300 of the cases are specifically in Texas. Hospitalization has occurred in about 17% of the cases, which is what we would expect based on historical hospitalization rates for measles. And 2 people have died. 1 is confirmed, the other is under investigation. The confirmed death is in an unvaccinated 6-year-old child in Texas, and the death that's under investigation was an unvaccinated adult in New Mexico, where measles infection was identified posthumously. Are we in an unprecedented situation? Measles was considered to be eliminated in the U.S. in 2000. However, every year, measles cases are still reported. The number of cases that we have now, however, is definitely higher than what we've seen in a number of the previous years. The current number of cases so far this year exceeds the total annual cases in all years except for 2 of the last 20 years. In 2014, we saw 667 cases of measles, and in 2019, there were 1,274 cases of measles in the U.S. And if measles is not contained, these outbreaks aren't contained within 12 months, then the U.S. is at risk of losing that elimination status for measles.
Thanks, John. So basically, what I heard there was that 2 people had died. And whenever the public hears about death, that's scary and causes a lot of concern. When I look through social media platforms, I'm seeing 2 schools of thought around measles outbreak. Likely based on the poll, there's about 30% of people who are saying, what's the big deal? It's a routine childhood illness. I had it as a child. It was featured on a Brady Bunch episode. It's not a big deal. And then, of course, you've got the majority who say it's a serious illness. Now, what I realized when I started hearing about measles outbreak is I didn't really know that much about measles because I haven't had to think about it because of vaccination. Can you give our listeners a brief overview about measles, the most common symptoms, what is the most common course of illness, and who may be at the most risk of experiencing severe complications and maybe even dying from measles?
Measles is a highly infectious airborne viral pathogen. Up to 90% of susceptible individuals will contract measles following an exposure. Susceptible individuals include those who do not have any sort of immunity to measles. So those would be people who are unvaccinated or who have not been previously infected. Prior to the measles vaccine, virtually every person acquired measles before adulthood, but this is not the case in the post-vaccine era. Most people who get measles will recover recover without complications, but it is still a serious disease with the potential for severe outcomes. Those individuals who are at greatest risk include children under the age of 5, adults over the age of 20, pregnant women, and immunocompromised individuals. Common symptoms of measles include rash, fever, cough, rhinorrhea, and conjunctivitis. And potential serious complications of measles include hospitalization. Potentially 1 in 5 people will be hospitalized. Pneumonia with an incidence rate of about 1 in 20. And this is the most common cause of death in children due to measles for this complication. You can see encephalitis in up to 1 in 1,000 patients, and then death in up to 1 to 3 out of 1,000, as well as blindness. And then for pregnant women who get measles, it increases the risk of pregnancy complications. So definitely potential for severe outcomes, but majority of people will recover without complications.
Well, when you cite a 20% risk of hospitalization, it really underscores the importance of vaccination. And we know that we have a measles vaccine, and that's our primary or only prevention method against the measles is the MMR vaccine. We both also know that vaccine skepticism has increased over the past 2 decades. And recently it has become worse. One of the reasons that is cited is really over the COVID-19 vaccine. Give me a brief history about the MMR vaccine and really describe for our listeners how the MMR vaccine is a lot different than the COVID-19 vaccine.
The measles vaccine became available in 1963 with the National Measles Vaccine Program. It launched as a single dose vaccine, and following the rollout of that, we saw a notable drop in cases, particularly in the late 1960s and 1970s. And by the 1980s, we had cases down to less than 4,000 cases per year, compared with over 500,000 cases before the vaccine. As time went on, there was several other measles outbreaks, and eventually that led to the change in the recommendation to get 2 doses in 1989. And this is what the current recommendation is for the dosing schedule that we have right now. Due to declining cases, the number of cases was low enough to consider measles to be eliminated in 2000. But we still can see spread of measles in pockets where vaccination rates are low, and we do see cases of measles every year. As far as the vaccine goes, it is highly effective. Following 1 dose of the measles vaccine, approximately 93% protection against measles, and then following that second dose, up to 97% effective. The duration of immunity is probably lifelong in most individuals. This is because the MMR vaccine provides a sterilizing immunity against measles, which means that it induces a strong, long-lasting immune response, which prevents infection and transmission, which is different than vaccines such as COVID-19 or flu vaccines. These are neutralizing vaccines, which will prevent or attenuate disease symptoms, but not necessarily always prevent infection or transmission following vaccination. You're more likely to see waning of that immunity over time, where you might need boosters as well. Different type of immune response and different types of vaccines.
Thanks for that explanation, John. I think that's helpful to describe the difference between vaccines. The MMR has been on the childhood vaccine schedule for a long time now. And you mentioned that most of this outbreak has been among unvaccinated children and adolescents, and that we see small outbreaks in areas where maybe there's no vaccination or under vaccination. So I'm curious, what is the overall vaccination rate with the MMR in the United States right now? And specifically in Texas, where we've seen the largest outbreak. And the reason I ask that is there is fear that there is growing skepticism, especially around the U.S. childhood vaccine schedule.
Overall vaccination rates for just childhood immunization series in general have unfortunately been declining over the recent years. In 2019-2020 school year, it was around 95%. Prior to that, for the last 10 years preceding that, it held steady at that 95% nationwide coverage. But in 2022-2023, we saw that dip to 93%. And then in the 2023-2024 school year, it went below 93%. And this is important for measles in particular, as the vaccination rate that's required for herd immunity to protect those that may not be vaccinated is 95%. And this is just due to how infectious measles is. You really need to hit that 95% target. For measles vaccination rates specifically for that 2023-24 school year, data for children that are enrolled in kindergarten on a national level, 92.7% received 2 doses of the MMR vaccine. Definitely below that 95% target. But also to your question around where the outbreaks are occurring and what the vaccination rates look like in those locations, Texas, for example, had an MMR vaccination rate for the 2 doses of 94.3%, pretty close to that 95% target. However, the outbreak in Texas is primarily concentrated in Gaines County, which has a significant Mennonite population, which typically has lower vaccination rates. I found that the childhood vaccination rate overall in Gaines County for that school year was around 82%. Definitely quite a bit lower compared to what the state average looks like.
We're nationally a little bit under herd immunity, and unfortunately that vaccination rate is falling. I would think during a measles outbreak, probably our number one priority is trying to vaccinate under-vaccinated or non-vaccinated children and adolescents, which appear to be where the outbreaks are occurring. We know that with the MMR vaccine, based on survey after survey, fear of autism is the most cited reason for a parent not having a child receive an MMR vaccine. So I want to have a discussion about why is there a fear of autism with the MMR vaccine other than anecdotal evidence, and what evidence exists to suggest that there is no link of autism with the MMR vaccine.
One of the sources of misunderstanding is a study that came out in 1998 that was published in The Lancet. It was a study looking at 12 children, and the study at the time suggested a possible link between the MMR vaccine and the onset of autism. However, investigation in this study later on found that the data did not support the claim, and there was credible evidence of research malfeasance, including falsified data, conflicts of interest, and flawed methodology, which ultimately led to this paper being retracted by The Lancet in 2010. That was one of the sources of misunderstanding. And in terms of the data that refutes that lack of link between the MMR vaccine and autism, this has been confirmed by numerous studies over the past 2 decades. I'll just highlight the 2 larger studies. One was a 2002 publication in the New England Journal of Medicine. It was a population-based retrospective cohort study in over 500,000 children, and they found no difference in autism rates between vaccinated and unvaccinated children, concluding that there was no evidence of increased autism following the MMR vaccine. More recently, there was another large study that was published in the Annals of Internal Medicine in 2019 in over 650,000 children with over a 10-year follow-up. Again, no increased risk of autism was found after the MMR, including among children who had higher genetic risk of autism. Overall, there are no credible data to support a link between the MMR vaccine and autism.
So I appreciate you providing that information. As healthcare providers, whenever we have a patient who has some vaccine skepticism or hesitancy, instead of saying there's no link, it's a good idea to be able to provide information to explain beyond just saying there's no link. It's because we have this data. I think that helps build confidence. Another myth that I've read, we know that the MMR vaccine is a live attenuated vaccine versus a inactivated vaccine. And in some instances with a live, we can have some viral shedding occur. And many on social media say the MMR vaccine actually causes measles. And many outbreaks are due to the vaccine strain measles versus the wild strain of measles. Is that actually true, John?
No, that is not the case. The MMR vaccine, like you said, is a live attenuated vaccine, which means it is a live virus, but it is weakened. After vaccination, the virus may replicate some in your body. In other words, it's replication competent, but this is what leads to the induction of that protective immunity. But this does not actually cause infection in people who have healthy immune systems. With that being said, you should avoid using live vaccines in people that are severely immunocompromised, as well as pregnant women due to the theoretical risk of crossing the placenta. This is true with all live vaccines, not just the MMR. But as far as detecting that vaccine strain measles, testing has shown that a PCR can sometimes detect this in people following vaccination for up to 4 weeks. But again, this is not a sign of infection or disease. It's just that your immune system has been exposed and it's responding. There was a study by Nationwide Children's Hospital in 2024. It was a retrospective study that looked at 127 patients following the MMR vaccine, and they took nasopharyngeal specimens, and about 1/3 of those had measles vaccine virus detected within 30 days following the first dose of the MMR, and most were within 14 days, but up to 28 days was seen. This wasn't an infection, it was just detection of that. So ultimately, if you have someone where you are concerned about a measles infection, maybe they have a rash, I think it's always good to evaluate if they've had a recent MMR vaccine, particularly within the last month, and if so, when possible, to try to distinguish between vaccine type and wild type measles to determine whether or not it's actually a true infection.
I think that's really good information. A lot of things spreading on social media that aren't quite accurate information. Earlier in the podcast, you mentioned that initially the MMR vaccine was recommended as just a 1 dose. And then subsequent to 1989, it's now recommended as a 2-dose series. So there is a large proportion of adults born between 1963 and 1989 who have probably only received 1 dose of the MMR. For those individuals, should they go out and get a second dose because of these outbreaks?
In general, adults who are not at high risk are considered to have presumptive immunity if they've only received the 1 dose of the MMR vaccine. High risk categories include healthcare workers, anyone planning international travel, or those attending post-secondary educational institutions. Another exception might be individuals vaccinated between 1963 and 1967, not because of the 1 dose that they've received, but because initially the MMR vaccine was an inactivated vaccine, which was shown to be less effective than the live attenuated vaccine that we have currently. So in those cases, a booster may be warranted. In cases of outbreaks, I would recommend that individuals follow state and local guidance and consult with their healthcare providers. Getting a second dose in adults who've only received 1 dose may be recommended. For example, in Texas, the Department of State Health Services is currently recommending that teenagers and adults who have previously only received 1 dose of MMR vaccine receive a second dose. And we know that going from 1 dose to the second dose does increase the protection that you get, as approximately 7% of people will not respond or seroconvert after their initial dose. So that second dose really just covers that gap. But in general, if you've only received 1 dose and you're not in one of those high-risk categories, you're considered to have immunity. So it's not an automatic recommendation that you have to go out and get a second dose. But if you are in an area with an outbreak, just consult local state guidance and your healthcare provider around what is recommended for your particular situation.
So I can tell you that I have no idea where my vaccine records are. And while I know that I've received 2 doses, I would say that a lot of people that aren't in healthcare probably don't know if they've received 2 doses and they can't locate a vaccine record. So should they go get tested to see if they have immunity against the measles before they go out and maybe get a second dose?
In general, serologic testing is not recommended post-vaccination in particular. Per CDC, if you know that you've had 2 doses, this actually supersedes any subsequent serologic testing results that you might get. So even if you did get tested and the results were negative or equivocal and you have had those 2 doses, you would not be recommended to get an additional MMR dose. Because keep in mind that checking antibody titers doesn't capture the full picture of your immunity. It doesn't account for T cell and B cell immunity that are also providing protection. So in general, serologic testing is not really recommended for most individuals.
All right. I appreciate that. So it sounds like if I was on an airplane and someone next to me had the measles and I was notified later that I was exposed to measles, as long as I have had 2 doses, I am considered protected. But let's say in the situation that I'm either not vaccinated or under vaccinated, what do I do if I've been exposed to measles?
This question is getting at what's called post-exposure prophylaxis, and that's really only recommended, as you alluded to, in persons that do not have that adequate presumptive immunity. Evidence of immunity includes documented receipt of the vaccine, if you've been previously infected, if you have laboratory evidence of immunity, or if you were born before 1957, with the caveat that healthcare workers that were born before 1957 who don't have evidence of immunity or who have never been vaccinated may consider getting the vaccination. Additionally, if you are immunocompromised, regardless of whether or not you're considered to have that immune status, you would still be recommended to get post-exposure prophylaxis. The options that you have for post-exposure prophylaxis depend on the timing of the exposure. The first option is the MMR vaccine itself, and that is the preferred option if you are within that 72-hour window of exposure in most populations. Exceptions would include children less than 6 months of age, pregnancy, and those who are severely immunocompromised, as you're not eligible to receive the vaccine. If you are outside of that 72-hour window, but still within 4 to 6 days of exposure, then another option is immune globulin. And this is actually the preferred option in some populations, such as pregnancy and immunocompromised individuals, as well as young infants. So for infants, maternal antibodies do provide some protection, but typically wane around 6 to 12 months. So infants less than 6 months would still be recommended to receive immune globulin prophylaxis. And then one last thing I would just note is that you should not give both the MMR vaccine and immune globulin, as it'll decrease the effectiveness of the MMR vaccine.
So one just quick follow-up question to that. Getting an MMR vaccine after exposure, if you're under-vaccinated or maybe not vaccinated at all, how effective is that, since we know it does take a little bit of time to build up antibodies after vaccination?
There's actually been several published studies that have evaluated MMR for post-exposure prophylaxis, and the MMR vaccine does appear to be effective if the vaccine is administered within that 3-day window, primarily in more limited contact settings. So exposures such as schools, or like you mentioned, if you're on an airplane, something like that. Studies in that setting have found that the vaccine effectiveness is up to over 90% if you get it in that time window. However, the post-exposure prophylaxis with the vaccine in settings with more prolonged close contact, such as household settings, may not be as effective in those cases, but the data and the studies are limited on that. For example, household studies obviously have a limited sample size, so we do have more limited data in those settings. And just in terms of the incubation period of measles, it's about 10 to 14 days. So it takes a little bit for measles to actually get going with the infection. And so you do have some time to start mounting an immune response if you get that vaccine on board more quickly. So if you do that within that 72 hours, then we have data to say that it may protect or modify the disease course. And so if you do get sick, still following the vaccine, it will likely be less severe than if you hadn't gotten the vaccine.
Very interesting. Recently, there was a change in CDC guidance to administer vitamin A in those that have measles. And I think for a lot of healthcare providers, this is new and different and don't necessarily understand the rationale for that. So can you explain why vitamin A was added to the CDC guidance?
Vitamin A deficiency increases your risk of complication due to measles and may actually delay recovery. And additionally, measles infection may also precipitate a vitamin A deficiency. So that's some of the rationale for why vitamin A might be considered for people with measles infection. But the evidence primarily supports that vitamin A decreases morbidity and mortality rates when given to children in more resource-limited countries where vitamin A deficiency might be more common. In the U.S., less than 1% of the U.S. population has vitamin A deficiency. But in terms of the evidence that I mentioned, there's been several Cochrane reviews that have looked at this. One review included data from over 1 million children across 19 countries and found a 12% reduction in mortality with vitamin A supplementation. Another review found a reduction in mortality following 2 doses of vitamin A in hospitalized children that were under the age of 2. As far as data demonstrating benefit with vitamin A in more high-income countries, in this scenario are more limited. One study, for example, in Italy, looked at hospitalized children, and it did not demonstrate a reduction in risk of complications or altered disease course with vitamin A supplementation. But in terms of guidelines, the World Health Organization does recommend vitamin A for all children with measles, regardless of country. And the CDC guidance that you mentioned, the CDC advises that vitamin A may be administered to children and infants in the U.S. and recommends it specifically in children with severe measles, so those that are hospitalized. I do want to emphasize that vitamin A does not prevent measles. It's not a substitute for vaccination. Appropriate use of vitamin A overall is a low-risk intervention, but excessive use of vitamin A can cause toxicities. Vitamin A is a lipid-soluble vitamin, so it's difficult to excrete excess amounts that are in the body. And toxicities can include things such as damage to liver, bone, your central nervous system, and skin. So as a result, vitamin A supplementation is only advised under the supervision of a healthcare professional.
So I appreciate that last point. We need to make sure we let our patients know vitamin A is not going to prevent measles, and there is a risk of toxicity if there is oversupplementation. So I think that's important. Well, thank you so much, John, for joining us today on VerifiedRx podcast. I know that I learned something, and I hope our listeners did too.
Oh, thanks, Stacy.
Join us for more VerifiedRx podcasts. Subscribe today. Like us. Send us your comments. We'd love to hear from you. VerifiedRx is a prescription for success and is brought to you by the Vizient Center for Pharmacy Practice Excellence. Thanks for listening.